Hello and welcome everybody to the Cepheid Symposium here at the Association of Molecular Pathology meeting. We have several speakers for you today. Our first will be Dr. Charlotte Gaydos. Before I introduce Dr. Gaydos, I would like to give you a little bit of background about the subject matter. Chlamydia infection is the most common bacterial sexually transmitted infection in the United States, with over 2.8 million new cases estimated to occur annually. In 2010, 1.3 million cases were reported to the CDC. Chlamydia gonorrhea is the second most prevalent bacterial STI, or sexually transmitted infection, with an estimated 700,000 infections occurring annually, and with 309,000 cases reported in 2010. Both of these infections can result in pelvic inflammatory disease, which can cause serious and costly sequelae such as infertility, ectopic pregnancy, and chronic pelvic pain in women. New diagnostics that can provide rapid point-of-care results are urgently needed so that women and their partners can be treated at the clinic visit or at the clinician's office, because many patients do not return for the results. Cepheid Xpert CT and G test has undergone clinical trials in Europe and the US with very promising results. It is pending review at the FDA. So having said that, I'd like to introduce our speaker for today, speaking with a presentation titled Cepheid Xpert CT and G, an exciting and promising new point-of-care rapid test to address the epidemic of chlamydia and gonorrhea. Our speaker today for this first subject is Dr. Gaydos. Dr. Charlotte Gaydos is a professor in the Division of Infectious Diseases Medicine at Johns Hopkins University, with joint appointments in emergency medicine, epidemiology and population, family and reproductive health, and the School of Public Health. She is the director of the International STD, Respiratory Diseases, and Biothreat Research Laboratory. Dr. Gaydos has received her BS in Medical Technology and her MS in Medical Microbiology from West Virginia University. Her MPH and DPH were received from Johns Hopkins University School of Public Health. Dr. Gaydos has extensive laboratory experience with over 40 years of experience in microbiology. So without further ado, I'd like to introduce our first speaker, Dr. Charlotte Gaydos. Dr. Gaydos?
Thank you. I would like to thank the organizers of this symposium for allowing me to share this presentation with you today. So as we've already heard, chlamydia is the most common bacterial STI. 2.8 million new cases and estimated to occur annually, with 1.3 actually reported to CDC. Neisseria gonorrhea is the second most prevalent STI. About 309,000 cases were reported to the CDC in 2011. Both of these infections can result in pelvic inflammatory disease and lots of bad sequelae, such as infertility, ectopic pregnancy, and chronic pelvic pain. Why do we want to diagnose and treat STIs? Just a little background. It's been estimated that there are about 19 million new STIs in the U.S. annually, and the health consequences of these untreated STIs are significant for teenagers, particularly girls 15 to 19. They're very much associated with health disparities. For example, blacks are 18 times more likely to get gonorrhea than whites, and 8 times more likely to get chlamydia. Blacks only compose about 12–13% of the population, but they account for more than 50% of all HIV cases, 70-some% of gonorrhea cases, and almost half of chlamydia and syphilis cases. There's infant mortality, morbidity to consider. All STDs facilitate HIV transmission and acquisition, and it's been estimated that the healthcare cost to the United States is about $17 billion a year. This is my triangle of estimates of incident STIs in the U.S. You can see trichomonas is probably the most prevalent treatable STI. Chlamydia here, estimates, remember, 2.8. Gonorrhea, these are actually reported, 309 reported, but about 700,000 are estimated. And you can see these in perspective to HIV and syphilis, other STIs. Now, near-patient or point-of-care testing provides a rapid result for the clinician by detecting chlamydia at the index visit or gonorrhea before the patient would leave the clinic. This can dramatically reduce the time between the testing and the receipt of treatment by the patient. There's an increase in the overall treatment rate, and it's cost-effective and can prevent more pelvic inflammatory disease and other sequelae. We know that many patients don't come back to the clinic, and so this is why point-of-care testing is so very important. So our objectives today. We're going to discuss the Cepheid Xpert CT and G test. We're going to report the results of the European registration trial for determining the accuracy of this test compared with nucleic acid amplification tests. And we're going to discuss some effective characteristics that would make a near-patient test more cost-effective and prevent more PID. So let's talk about the European trial now. It's undergone its clinical trials in Europe, and to determine its accuracy, it was compared to a patient infected status. Now this PIS is derived from 2 additional nucleic acid amplification tests. The study was conducted in multiple sites in areas of high, moderate, and low prevalences. This is a cartoon that shows the cartridge in which the sample is placed. A very simple way to run the test. The swab is inserted into the vial and broken. You vortex and dispense the sample into the port, and then add a little binding reagent. Shut the lid and put the cartridge in the machine and click go and start the assay. Very, very simple. The platform design is also flexible. The Gene Xpert module can take 1 sample, 4 samples, 2 samples, all the way up to the Gene Xpert Infinity with random access, which will take 48 samples at a time. So, in this trial, there were 1,722 female and 1,387 male subjects. And they were tested by the Gene Xpert and also by 2 additional NAT tests. This assay was able to give a result on the first attempt for 97% of the samples that were tested. Pretty successful. The indeterminate rates had included about 159 error results, a couple of 17 invalid, and about 14 that gave no result. But when these were retested, most of these samples yielded valid results. So the overall success rate after the repeating of the ones that didn't give a result the first time was 99.6%. So this is an example of the screen, and you can see this is what shows up on the computer. This is an example that the chlamydia is not detected and gonorrhea with 2 targets is detected. And I think you can see here it's 1 target that's starting to come up after 20 cycles of real-time PCR. And here's the second gonorrhea target. Notice also that the internal controls are amplifying also, shown here in green and in yellow, the specimen control and the adequacy control. This is an example of chlamydia being detected, gonorrhea not being detected. 1 target here for chlamydia, you can see, and then the primary specimen adequacy and other control. So let's look at the results now. First, we're going to look at females and endocervical swabs. 1,710 samples represented here, and you can see that for the most part, we have agreement with the patient-infected standard. Remember, the patient-infected standard is derived from 2 additional NAT tests. So you can see there are very few in this 2-by-2 table. Here's the Cepheid results shown over here, and the total PIS here, 78 and 16, 22 were, 32 were negative. So you can see that these give excellent results, sensitivity of 97.4 and a specificity of 99.6. So let's move on now we're still talking about the girls and talking about vaginal swabs. Again, 1713 specimens were tested. Pretty much perfect agreement. There were some here that were negative by the Cepheid test that were positive by the PIS. But overall, this gives a sensitivity of 98.7% and a specificity of more than 99%. Okay, moving on now, still talking about the girls, we have the female urines. Again, almost perfect agreement between the positive positives and the negative negatives, showing a sensitivity of 97.6 and a specificity of 99.8. Just doesn't get much better. Now we're going to talk about female and Neisseria gonorrhea. So you can see here lower prevalences of gonorrhea in Europe than what we see sometimes in the United States. 22 positives by both methods, showing a specificity and sensitivity of 100%. Okay, now the vaginal swabs for gonorrhea in the women. Again, almost perfect agreement. A couple of discordant samples here, but giving us a sensitivity of 100% and a specificity of 99.9. Okay, let's talk about the female urines for gonorrhea now. Again, almost perfect agreement, only a discordant here and a discordant here, and you can see this gives us a sensitivity of 95.7 and a specificity of greater than 99%. Okay, what about the boys? The boys are a reservoir for transmitting STDs to their female partners, and so we want the males to be tested too. So let's look first at urines. Men don't like to have urethral swabs taken, and so our claim here is for urines, which is what the CDC recommends as the desirable specimen of choice for testing men for chlamydia. Okay, here you can see that, again, almost perfect agreement, a couple of discordants only, for a sensitivity of 97 and a specificity of 99. Okay, what about the boys for gonorrhea? Again, almost perfect agreement with our patient infected status for a sensitivity of 98 and a specificity of 99. Are you bored yet? We'll move on to the next section here and talk about not the patient-infected standard, which is derived from 2 gnats, but let's look at each of those 2 gnats individually. You can do this in a couple of ways. One way is the Venn diagram here, and so as not to bore you with so many of these, I'll just give you this one example. Here's the comparison between the Gene Xpert up here in this circle, the Becton-Dickinson test down here, and the GenProbe assay here. So you can see you can represent this in this way with 76 of the samples showing positive by all 3 assays. And here's one assay that's positive only by BD and Cepheid, and another 4 assays that are positive by GenProbe and the Gene Xpert. And you can see there's a couple here, 2 here, 2 here, and 9 here that were positive only by the individual assay alone. So a different way of looking, but it gives a nice picture. Okay, so let's tease these out a little bit. Here, shown across the top, is the Gene Xpert versus the BD versus the Gene Xpert, and the GenProbe versus the Gene Xpert. So 1,710 endocervical specimens, and you can see very high sensitivity here, a little bit lower sensitivity for the BD, and a little bit higher sensitivity for the GenProbe assay here. So, but all in all 3 tests performed very well. Okay, let's move now to the urines for the girls. Same format that we talked about before. High sensitivity for the Xpert, a little bit lower sensitivity for the BD assay, and about the same sensitivity for the GenProbe versus the Xpert. Again, switching now in the females to gonorrhea, 1,710 samples, 100% sensitivity for the Xpert and 95 for the VD and 100% for GenProbe. Now let's talk about the urines. Again, high sensitivity and high specificity. I'm not even mentioning because they're almost always perfect. But you can see overall accuracy 99, 99, 99. Pretty boring, but in a good way. So let's move on now to talk about the boys. Here, 1,386 samples. Again, excellent sensitivity of Gene Xpert plus versus the other two. And then the Becton Dickinson versus the Gene Xpert head-to-head, the GenProbe versus the Gene Xpert head-to-head. Excellent sensitivities and specificities. Okay, let's talk about gonorrhea now in the boys, 1,387 specimens, and you can see here very high sensitivities and specificities, much like for all of the other samples and all of the other organisms. So in summary, CT demonstrated sensitivities for the endocervical, vaginal, and urine samples of 97, 98, 97% respectively in the women, and in the men for urine, a sensitivity of 97.5% with near perfect specificities, as we've mentioned. For gonorrhea, the results demonstrated endocervical, vaginal, and urine sensitivities of 100, 195 in women, and in men for the urine, a sensitivity of 98.0. So, in conclusion, these results of the European trial indicate that the Cepheid Xpert assay can be used to accurately and rapidly test and treat the infected patients at the site of care. It can potentially prevent more sequelae due to chlamydia and gonorrhea while also being cost savings. And we're going to talk about that in a little bit. So we're not going to take questions now. We're going to move on to a little bit more that I want to cover for you today from some studies that we have done. The first study that we did was we asked women in our clinics how long they would wait to get a result and how much they would pay and what specimen type they preferred. These were 371 women attending our STD clinic in Baltimore, Maryland. So as far as the preference for the specimen type, and these were after they'd had all three samples obtained, 50% said they prefer to have a vaginal, 33% said they would rather have a urine. So taken together, obtaining the sample themselves, whether it's a vaginal or a urine, almost 85% said that they want to collect their own sample, as opposed to 15% that said they wanted the doctor to collect the cervical. How long would they wait for a result? These times that were given them as choices were 20 minutes, 40 minutes, and 60 minutes, 90 minutes. So you can see a kind of a spread here, but most of the women only really wanted to wait 20 minutes. But if you add a whole hour here, you could probably get a fair proportion of these who would be willing to wait. One way this could work with the Cepheid test, which does take an hour or a little more, is to start the test when the women walk in the clinic and not after they wait a half an hour to see the doctor. So you can take an advantage of starting this test when they walk in the door. Just for the fun of it, we asked what would their willingness to pay if they could buy this test over the counter. Most people in our inner city clinics only wanted to pay $10, but there were some that would pay up to $50. So just an interesting little questionnaire that we did. We asked them if they had to be rescreened, because CDC recommends that they get rescreened in a year. Or, I'm sorry, every year, or that they get rescreened once they've had a positive test within 3 months. 46% said they'd like to have it done at home, and about 47% said they would like to have it done in a clinic. And then we asked them how hard or how easy was it for them to collect the vaginal swab. 62 and 33% said it was either easy or very easy. Only, I think, one person said it was hard, very hard, and no one said it was hard. So women are fairly happy to collect vaginal swabs. Okay, I'd like to end the presentation today with a study that we did that's just been published in Sexually Transmitted Infections this month, ahead of print. It's available online. And what we did was a comparative effectiveness study, which included cost effectiveness, but we looked at a desirable, rapid new point-of-care test that we thought might be coming down the line for the detection of chlamydia among women in a clinical setting. So this was a model. We did a decision tree, and this was constructed based on real data where possible, women attending an STD clinic, and then the model brought it up to a hypothetical cohort of 10,000 women. So the model incorporated programmatic screening costs, the treatment costs, the medical costs that would be averted through prevention of PID and its sequelae, antibiotic costs, hospitalization costs. Every point in the parameter values that we could, we used primary data. We had, of course, used some published data for the percent of women who would develop PID, and some unpublished health data that we collected. So this model was based on 149 participants that had 14 infections that were detected by a vaginal NAT test. 13 of the 14 were detected by this promising new vaginal point-of-care test for a sensitivity of 92.9 and a specificity of 98.5. The number treated for the point-of-care versus the NAT test was also calculated, and the length of time that the women were willing to wait for the point-of-care test result. And we used a range of 30 to 90 minutes for these 149 women. We also looked at those who would be treated empirically based on the clinician's decision, and this was actual real data. So the sensitivity of the vaginal point-of-care test was 92.9, as I mentioned, and the sensitivity of the NAT test, which was the comparator test, was 98.0. Our prevalence was 9.4%, and you can see here the willingness for time to wait in these 149 women. 47% were willing to wait 40 minutes, 28%, 60 minutes, and only 15% were willing to wait 90 minutes. So calculating in the model for the women who would wait, there was assumed to be a hypothetical treatment rate of 100%. And for the women who would not wait, a treatment rate of 93.7%, because if they don't wait and they don't come back, then a disease intervention specialist has to go find them if they can and get them treated. The published azithromycin success rate was 97%. So additional parameter estimates in the model was in the NAT strategy, only 93% of the patients actually got treated. In the NAT strategy, 59% received treatment if they had to require DIS or disease intervention specialists to go out and find them. So considering the ones who got treated presumptively and the ones that the disease intervention specialists had to find, 59% of the ones who had to be contacted outside the clinic received the treatment, and 40% did not. So women in the point-of-care strategy who required DIS intervention was none. Then the rest of these are published data, well-recognized published data for whether or not a woman might develop PID between the time she had a test in the clinic and the second visit when she came back to get the results has been done by several investigators, about 2.2%. PID in those women who never got treated within 1 year is considered to be 30%. Those patients who actually developed PID, the inpatient that had to have inpatient treatment rather than outpatient treatment was about 11%. Of the ones who got PID, 22% were expected to develop chronic pelvic pain, 4% ectopic pregnancy, and almost 10% were considered to develop infertility as a result of having PID. Let's move on. So in our hypothetical cohort, as we ran the model, we would expect that the NAT test would detect 921 cases of chlamydia, whereas the point-of-care strategy at its sensitivity would detect 873 cases of chlamydia. But let's see how this turns out because of treatment. So the expected number of cases of PID for the NAT strategy was 80. However, the expected number of PID cases based on the point-of-care strategy was 66. So 14 more cases were prevented, which is a decrease of 18%. So the cost associated with treating these women for the NAT strategy was $782,000 because a disease intervention specialist had to go out and find the women who were infected who never came back, if they could find them. The cost associated with the point-of-care strategy for these 10,000 hypothetical women was $712,000, which results in a savings of about $5,000 per case of PID prevented. So you can do a sensitivity analysis in these models in which you can vary one estimate or one parameter, whether it's the specificity or whether it's the sensitivity or whether it's the cost or whatever parameter, you can vary in a univariate method. In other words, you can say, what if the sensitivity were 80% or what if it were 100%? What if the wait time was 40 minutes? What if it was 60 minutes? What if the specificity or the sensitivity analysis of those who would wait could be ranged from 20 minutes to 90 minutes? So you can vary all of these. You can vary the cost of the test above and below what your baseline estimate is. So the best case scenario, if you were going to do single sensitivity analysis for one thing at a time, is that the point-of-care test prevents more PID. We've already seen that, 14 cases more prevented, and saves money at $5,000 per case of PID. So doing the one-way sensitivity analysis, varying one of these things at a time, we came up with the results that the point-of-care test would dominate the NAT strategy if the point-of-care test's cost were less than $41.52. Or the point-of-care test would dominate the NAT strategy if the sensitivity of the point-of-care test were greater than 87.1%. So this is the best case scenario when you're doing a sensitivity analysis, varying the results higher and lower than your estimate that you came up with, because who knows if the estimate's exactly right. So the best way to see whether or not things would change is to look at a higher or a lower sensitivity or a higher or a lower cost than your baseline estimate. So you can also do in the model with Monte Carlo simulations multivariate sensitivity analysis so that you can vary more than one thing at a time. This is a pretty complicated chart, but based on what you know from before, where you just vary one thing at a time, the cost or the sensitivity, then you can also vary more than one thing at a time. So I'll try to walk you through this and see if you can understand. So we just did, for an example, 5 different scenarios. Obviously, you could pick any scenario that you wanted to vary. To say, what if the sensitivity were this, and what if the wait time was this, and what if the wait time is this. So the first strategy A, the sensitivity was set at 92%, which is what we found, and we set the cost at $33.50. So this was the strategy that we described as the best case. If they would wait 40 minutes, more PID would be prevented by the point-of-care test, and the cost would favor the point-of-care test under these circumstances. Now, second case, what if the tests were to cost $20 and the women would only wait 30 minutes? So here you're picking a couple of things to vary at the same time. The point-of-care strategy would still dominate, and 20 more PID cases would be prevented at $11,000 per case averted. However, if in scenario C, the point-of-care sensitivity dropped as low as 80 and the wait time was still kept at 40, then the NAT strategy would dominate. Similarly, if the cost of the test were $40, the sensitivity of the point-of-care tests were 80, and the women would wait 60%, then the NAT strategy dominates. And in case scenario E, if the point-of-care tests were as low as 70% and the women would wait 90%, then the NAT strategy would dominate. So these are just examples of things that you can vary. You could plug in the model anything that you wanted to set your own parameters. These are just the ones that we chose. And so this is another way to look at it, is that the point-of-care test is more cost-effective than the NAT test when these 3 parameters that are examined fall into the dark gray. So the 3 parameters that we looked at here were the cost of the test, the sensitivity of the test, and the percent of women who would wait. So shown in the light gray is the NAT strategy would dominate, and shown in the dark gray would the point-of-care strategy would dominate. So the parameters that were changed were the cost here, $20, $30, $35, and $40. And here, shown on the x-axis across here, is the sensitivity of the point-of-care test. So you can see the closer it's getting to 100%, the more cost-effective the assay is. Again, here, if it costs $20, just getting close to 80%, you'll have the point-of-care test dominate. And then shown on the y-axis is the percent of women who would be willing to wait. So you can see that these dashed lines across the middle here would indicate sort of the break-even point. It shows the best case scenario for the sensitivity of 92%. So, and a wait time of 40 minutes and 47% of women waiting for 40 minutes. So here is the amount of the women who are willing to wait right across here, 47%. So you can see that many circumstantial parameters are important in deciding the comparative effectiveness and also the cost effectiveness. So in conclusion, I'd like to say that the newer point-of-care tests that are coming down the line and are soon to be available to practitioners are likely to be sensitive enough to compete with our gold standard NAT test that we've been using for a few years. When women will wait to get their point-of-care test results, more infected women are treated and are not lost to follow-up. So this willingness on the part of the women is important, and it depends on the test processing time. So in order to be more effective, the processing time should be less than 40 minutes. In order to be cost effective, the pricing needs to be competitive. So all things that are important when you're looking at comparative effectiveness and cost effectiveness. So I'd like to acknowledge Wei Wang, who has run the model with her mentor Diane Blake at the University of Massachusetts Medical School at Worcester, Massachusetts, and our collaborators here who were very instrumental in gathering the data, Mary Jack Goheen and Diane Blake. So I think that we can probably take questions now.
Great. All right. Well, thank you, Dr. Gaydos, for a very interesting presentation. I appreciate it. We actually do have about a few questions that were submitted, and we'd like to take just a few minutes before our next speaker to answer these questions. The first one is what are the biggest challenges faced today by healthcare providers with contact tracing, especially with younger patients?
Well, contact tracing and partner notification has always been a problem. And the challenges are to get these partners treated. We have some little programs that CDC's recommended called EPT, or expedited partner therapy, where you can give a woman therapy to give to her partner, but this is not legal in all states. And so most of the way that we have to treat the partners so that the women don't get reinfected is to try to find these partners, or have the women name their partners or tell their partners to come in and get treated. And as you can imagine, young people don't like to tell their sexual partner, if they even know their name, that they might have been exposed to a sexually transmitted disease. So it doesn't work very well. There are some new programs that are being designed so they can know, is a newly available web-based method of sending your partner an anonymous email. And so we're trying to have new things to meet these challenges, but it's always a problem.
Right. Okay. Second question we have asks, would bringing NAT technology near to the patient, either in the ED or out in the community where young people can come to, say, like a mobile clinic, would that help improve how we test and treat patients?
Absolutely. We know that patients in the emergency room are never going to be seen again, and so there's a lot of over-treatment of patients that come to EDs, and also we know that most of STDs are in young people, and so being able to access them in, for example, in the community where they gather is a capture point would be a wonderful thing. Certainly this could be done on a mobile van. We have vans in Baltimore that go out on the streets and sit outside of schools after school, so that a student can come out and step on the van and get a test. And right now they have to take the test, and then they have to find out about the results 2 weeks later. But if they could find out right away and get their treatment, then this would bring a considerable decrease probably in the epidemic that we see in our young people in this country.
Good, good. All right. Our next question asks, what key design features in the Cepheid test do you see as to be kind of game changers, if you will, in how we test for CT&G in the community today?
Well, I think the game changer, of course, is being able to treat the patient before they leave whatever clinic or van or emergency department that they are being treated in. And the fact that it's a simple design, and in my lab, I think that I could probably teach an 8th grader how to run this test. It's so simple. So it is very simple. It gives you chlamydia result and a gonorrhea result, and it also gives you a specimen adequacy control results. So you know, for example, if a woman who said she collected a vaginal swab just collected an air swab and said, here's my sample, you would know that because the specimen adequacy control would fail. So I think the ease of performing the test, the fact that you have internal controls, and the rapidity of being, and the simplicity of being able to get those results so that the patient could be treated before they leave. And another thing that I think people don't think about is that if you're able to sit a young person down and tell them right away that they have chlamydia or gonorrhea, it's an opportune time for counseling and to be able to tell them right there face to face that they need to tell their partner, as opposed to if they come back in 2 weeks and maybe they get the result from the desk at the clinic and they don't really see the clinician. So it's an opportunity for immediate counseling that would strengthen the fact that they need to tell their partners and that they need to follow up and take all of their medicine.
Right. Okay, excellent. Another question here. Actually, we've only got looks like a couple more. Are there NATs in the marketplace today that are rapid and also meet sensitivity and specificity in the high 90s?
Well, certainly we have NATs that meet high sensitivity and specificity. They've been in place for quite a few years. However, they're not quite rapid. Now, you can do a PCR test in 2 hours, but they have to be done in a laboratory, and so they have to be accessioned, and they have to be the DNA has to be extracted, and then the results have to go back, and so there are tests that are sensitive and specific, but they are certainly not rapid, so that you could use those results and get them back to the clinician in time to treat the patient immediately.
Right. Now, with regards to the Cepheid test, how long does that take to run?
It's a little over an hour.
Okay, gotcha. All right. And what looks like our last question here is, based on your study's sensitivity analysis, what is the ideal cost for a NAT point-of-care test with, all things being equal?
Well, again, as I mentioned before, it depends on a lot of other things, like the sensitivity and how long the woman's going to wait and how many women get treated. But I think in our one-way analysis, we showed that if the costs were less than $40, then they would be competitive, depending on the best-case scenario for the other parameters that you would measure. So it's a slippery slope as to which of the parameters that you lay out as to how well the cost interdigitates with all of the other parameters.
Understand. Okay, great. Well, thank you once again, Dr. Gaydos, for an outstanding presentation, and we'd also like to take this time to thank those people that were able to tune into today's broadcast. And so we'll thank you, and we'll move on to our next presenter.
Okay, thank you very much.